can use it.
Hello, everyone, and welcome, welcome. We'll get started in just a few minutes. There are like over 200 of you registered. So we're going to give a few minutes for everyone to get logged on. I saw so many in the waiting room. We thought we'd go ahead and let you come in and listen to our little fun music while we wait. And do drop in the chat who you are, where you're joining us from tonight. We'd also love to know if you've been with us all week. And then we'll get started in just a few moments.
No way. Can you hear me? I can't hear you.
We can. And hello, everyone, and welcome. Now, I'm not sure how we got that dual screen, Doctor.
You have both. What do you have? Two slides?
Wait. Window.
What do you say?
Uh,
Sets of slides?
we're seeing you twice. We'll fit up with that. But I want to welcome everyone. Thank you for joining us. As everyone comes in, I want to take just a few minutes to introduce my co-conspirator, our presenter, Dr. Cassandra Henderson. I'm trying to get this to get out of widescreen so I can see you guys better. There we go. Dr. Henderson, oh my gosh, I could talk all night about all of her work and her many accomplishments. If you have been to any of her workshops with us before, you know that she is a maternal fetal medicine specialist in New York City. She also is just stepped down as the section chair for the National Medical Association. She has consulted with the NIH. I believe she still does, as I
Still do.
frantically get over to her bio and try to close
It's
all these,
fine. It's good. I'm glad to be here. I'm
and still
actually,
does.
that's good.
And she is serves on a number of leadership roles with the American Dietetic Association. We are so excited for her to share with us tonight her insights on mamas who may have chronic illnesses and how they can still provide human milk for their babies. Without further ado, welcome, Dr. Henderson. Thank you for sharing your knowledge with us, and I will turn the floor to you.
Well, thank you so much, everybody, for joining us on a Thursday night. I hope the weather is good and you guys have had a wonderful day. I am so honored and pleased to be asked to talk to you tonight. As Marie said, I am a maternal fetal medicine person, have been for 40 years plus. I'm also a certified diabetes care and education specialist and a diabetology consultant. I was really surprised that I was asked to do this talk because while I am a big proponent of breastfeeding, it's not been a primary interest of mine as a high risk provider, primarily because, unfortunately, and what I found in the literature preparing for this, most people who care for people who have complicated pregnancies and most people who have complicated pregnancies put breastfeeding on the back burner, which is really unfortunate. Something that we have been doing, I've been doing, and what I've learned is that it really is just a really dumb thing to do. Most individuals who have a complicated pregnancy can certainly breastfeed with some support, and it's good for them and their baby. And I hope that after we do this for the next 40 minutes or so, that you will agree with me. I want this to be as interactive as possible. We are remote. Clearly, we're not together, and it's a lot of you, I think. I'm not sure. But if you will put questions or concerns or interests in the chat, Marie has agreed to monitor that, and, and intermittently during the presentation, she'll pull my coattail or give me a holler. I want to start by saying, giving homage to an organization I belong to. I'm a member. It is Otis. That's the Organization of Teratology Information Specialists. We use evidence-based material and projects to answer questions about breastfeeding, about pregnancy, exposure to vaccines, to toxic chemicals at work, to anything that might concern a pregnant person or a breastfeeding person about what they might be exposed to, rather than going to TikTok or Dr. Google, which oftentimes may be a perfectly okay thing to do. If you or anybody would just send a email, just or text, actually, you can do that to Otis. Someone will respond and give you evidence-based response to that question. It is very interesting that the Academy of Pediatrics, APA, has for years recommended that the breastfeeding be the feeding of choice for newborns for the first 6 months of their life, not to be supplemented by, chewed up food off your plate or any other baby food, but for the first 6 months that the newborn gets the breast milk, if that's possible. Certainly, some people don't want to breastfeed, which is perfectly okay, obviously. That is a shared decision making with the birthing parents. But if they can be convinced or encouraged or given help, it is preferable for the baby, and we will go through some of that. After 6 months, the feeding for the newborn should be supplemented with iron-rich food. It's interesting in the US, up to 80% of individuals who are about to give birth plan to breastfeed. But within a week, only 75% are breastfeeding. And furthermore, later after I'm sorry, 75% will breastfeed, but within a week, only 50% are breastfeeding. And by 9 months, the general population, about 31% of people are breastfeeding. Unfortunately, Black and other or marginalized individuals, somewhere in the 6 to 8% are breastfeeding by the time of 9 months. And there's a lot of reasons for that. Obviously, some people don't want to do it because they're going back to work, they don't like it. One story I sort of kind of took me aback. I had a resident a number of years ago, really into shared decision making and engaging patients, really didn't want to do episiotomies or any tears, worked really hard to make all of this natural and work with parents. And when she had her child, I thought, well, of course she's going to breastfeed. She does all that. She said, no. She said, it just makes me feel like a cow. I'm not doing that. Well, I mean, she was a great mom and great resident, but that was just her choice. So obviously, it's not something that you have to force anybody or browbeat them. But if individuals do want to breastfeed, we should be able to help them. There are a number of reasons that Black birthing people are not breastfeeding. One, they have to go to work, and it's just really hard to pump. And if they're at work and they're not an area where it's encouraged at their job, and often we're now getting into baby-friendly hospitals. It's when I trained in the 1970s and 80s, it was assumed that people didn't breastfeed. And as horrible as it was, there were standing orders for delivery that all you had to do was sign off. There were these nurses who were really good at binding breasts, and I mean, just crazy with a towel, and they would just flatten them out and just really chest, and they would use safety pins and they would have towels on until they went home, and we would give them injections of testosterone, which is just I can't believe we did that, but that was the standard of care. So starting with that, and then the history of slavery, where Black the enslaved women were their purpose was to increase the slave population because, of course, they couldn't import slaves legally anymore. So they used Black uterus to enrich the population of enslaved individuals to work the farms and do all the other stuff. Well, when they delivered, the babies were often separated and they were then sold. And then the owners would, the pregnant individual, once they delivered, would then become, would be, her breasts were then used to nurse the white babies, but then not hers. So her babies didn't either got malnourished or died. And that was sort of a culture that we had, over the last many hundreds of years. Then we had the Jim Crow laws that hospitals were not, they're separate, certainly not equal. And so there was not support or encouragement to do those things. And then we have the redlining, and that's about economic depravity. We know that part of in the U.S., one of ways to become financially sound and support yourself is the property. Well, in the redlining, the 1930s up to the 1960s when it became illegal, there was no opportunity to do that. And we know that taxes are based on home ownership and property taxes, and that supports schools and hospitals. Well, obviously, those areas where Black individuals were living in the 30s, 40s, 50s were not didn't have the money to support that stuff. As a result, healthcare and healthcare facilities were minimal, and that was did not, of course, support breastfeeding. That was low on the list. And you add to that the GI Bill. While it was good for the country and for people coming back from the World War II, their families were not given, Black people were not given the same benefits in returning to areas where they could actually use those. And so as a result, there was a lot of social determinants of health that support the fact that Black women do not breastfeed as often as they might otherwise. The women I care for have high-risk pregnancies, which always sort of like a sort of a scarlet letter. I don't like that, but that is they are in a category where really it's not that the pregnancies are risk, it's just that they require and can benefit from further, more intensive follow-up care intervention, having antenna up. And reasons for that are chronic conditions, chronic medical conditions, diabetes, hypertension, autoimmune particularly is a real big thing these days. We're becoming aware that a lot of things, and in fact, Marie was very kind to share an article that we look at that preeclampsia may well be an early sign of developing autoimmune conditions. So that affects women far more often than men. And birthing people who are young or who are very old, both of those extremes have a higher risk for complications and they can be deemed high risk. Multiples, twins, quadruplets, octagons, all of those are more complications, and they increase the risk for diabetes and abnormal placentation. And anybody who's had a previous pregnancy, complications, multiple miscarriages, stillbirths, small for gestational age, those are all high-risk pregnancies, and they will be followed more closely, and any lifestyle choices that may not be beneficial to the pregnancy. All of these individuals, all of these conditions may make it not only more likely that there may be complications in the pregnancy, but those people may not, I think I lost, may result in them being less likely to breastfeed.
Dr. Henderson, could we stop you for just a moment? For some
Sure.
reason, your beautiful face is on the screen twice, and
Okay.
then
Slides are not
power
there.
your PowerPoint slide is there, but it's small. We were trying to figure out how to remove one of your video screens.
Should I just get out just and get back in?
No, I don't think you need to log out. Has anyone ever seen it do this before? Where do you guys see Dr. Henderson twice? You don't see her twice? Yes, you do see her twice. Okay. You weren't there twice, but then all of a sudden you are.
So why don't I sign out and get back in? How's that?
Oh, okay, let's try that. Oh, some people see you three times. Okay,
Oh,
now
Jesus.
you're okay. Now no, okay, now just share your screen. Let's see if that works.
Uh,
Now they see you once, and so then
do you
try
see the
sharing.
slides? Do
They
you see
see you
slides?
once, they don't see your slides. Nope. Now it's showing you twice again.
Jeez. Okay.
But do you want me to share your
Yeah, if
slide?
you said slides. Yeah, if you said the slides, and then I'll just be one. How's that? No?
Uh,
I'll just get completely out and I'll get back in. How's that?
no, don't leave. I can share your slides. That's so weird. It was working fine. And then now it's giving me.
How's that? No?
Now you're not sharing anything. Oh, okay. Now, no, for some reason I don't know why it's showing you twice though.
It's either nothing or twice.
That's so weird. Maybe if I make it.
I'll just get out and get back in. How's that?
Thank you for letting me know. I thought, well, maybe I've done something wrong. We practiced 1,000 times.
Is that okay?
You're here once.
Okay. Let me share open the PowerPoint and see if I can share.
Just when we thought we knew Zoom, they would.
I know, we were practicing and it was working so well. Because she's speaking and the way her screen is not showing. Well, while we're doing this, anybody have any questions? Um, well, so can you do my slides then?
I can. I have it there, right? Okay.
Mm-hmm.
There we go.
Okay. Can you see? What are you seeing?
You guys can see it, right? And what slide number do you want me to?
Um, keep going. I did that. Go. That's where it was. Yep, go. That's where it was.
Okay.
Next. Okay, so these are the common medical complications that I deal with, and let's see is there now with black? We're black now, Jamie. Is that okay? Can you
And
see
you
it?
guys can see the full screen, correct?
No slides. No
They
slides.
can't, they
They
can't.
said in the chat. It said they can't see anything. Ay, ay, ay.
Really?
That's what it says in the chat. Oh, I see slides. Black screen. So
Hold on.
they're not seeing slides.
Oh, what do you guys see now?
Can you get the slides in the email? Yes, we can get slides in the email afterwards. Yes.
Now, do you
Okay.
guys see them?
Can you see it now? No. Ay,
Really?
ay, ay, ay. Uh,
Crystal can, no, no, really?
I'm sharing my slides. Yeah.
Now, yes. Okay.
Yes, yes, no, yes.
Yes, they're saying yes. Okay.
Okay. All right, good. So let's go next. So you have it or I'm going. Okay. Okay, next one.
Uh,
Am I moving or you're moving?
I'm, I'm moving.
Best laid plans.
Okay. Breastfeeding associated risk. Is that what you see, doctor?
I'm looking at lifestyle. Yes, smoking, tobacco.
Breastfeeding associated lower risk?
No, go
Well,
back. No, should be. Uh,
oh, I hate this. I'm sorry.
this was, we practiced. We did it ahead of time. I feel terrible. Oh, okay, I got it. I'm doing it. Can you see me?
We see you.
Okay, I'm able to move it forward. Can everybody see now? Yes? Common medical conditions?
Chronic medical conditions commonly affecting pregnancy.
Yes. Can
And
you see that?
they're saying yes, they see it. They
All
see the
righty.
screen and
Okay.
that's
So
okay.
these are common. So anyway, breastfeeding can lower risks for the birthing person, breast cancer, ovarian cancer, type 2 diabetes, and hypertension. In addition, for the newborn, for the offspring, it decreases infants who are breastfed ultimately have in their life lower risks of asthma, obesity. It actually I'll put in a couple of categories: improving immune system and decreasing complications are related to abnormal immunity and also metabolic changes. So the asthma, lower respiratory tract infections, ear infections, and then some metabolic changes. So type 1 diabetes, these decreased risk of cancer, leukemia, and also a lot of general infections, ear infection, GI infection, diarrhea, all of those are decreased in infants who are breastfed. We look at trying to increase the risk, the chance individuals will breastfeed. And one of the things that we've started that I certainly didn't think anything about when I was training, nobody even talked about it, but colostrum. It starts to being produced in the second and the third trimester, second trimester. But we really start looking at it more after 36, 37 weeks. There's some interest in collecting it to have it available for newborns that they can be supplemented with. And even some preterm deliveries, if it's more likely or a risk for delivering preterm, that might be a possibility. But the act of stimulating nipples to get colostrum may cause some contraction. So if someone's at risk for preterm delivery, that's not a great thing. But for term babies, collecting the colostrum is wonderful nutrition for the neonate. What I was thinking, so it is designed for that baby. So preterm colostrum, the contents are different than those of term. So it's a higher concentration of protein that the preterm infant needs. Colostrum is a sticky, thick, yellowish material that when the neonate eats it, it's sticky and it helps to coat the GI tract. And it also is something that I can't swear to this, but that's what the text said, that it smells like amniotic fluid. And the people who study this say that the amniotic fluid on babies' hands, and we have all seen babies start to suck on their hands, which is kind of cool. The smell of the amniotic fluid on the hands, so the baby's hands shouldn't be washed and cleaned and scrubbed as it did all the time that I was trained. The babies used to get cleaned and scrubbed and wrapped and put over in a corner until we finished preparing the mother. And then they got all wrapped up and went to the postpartum floor. And so the baby wasn't with the mom for the first probably hour as I was trained, but we don't do that anymore. So on the baby's hand, if it's not washed off and wiped, the amniotic fluid smells, the literature says, like colostrum. And that helps to get the baby, one, they're sucking on their hand when they get out, and then the smell encourages them to move to the nipple if they're put on skin to skin. And we'll talk about that. And I also have a little quick video for you to see a baby crawl. The colostrum is full of antibodies and white blood cell count, and it's a nice little vaccine for the baby. So not only is it thick and helps with the GI tract, but it also contains a lot of passive antibodies. So it's like a passive vaccine that helps the baby to fight some of the bacteria that they're all of a sudden thrown into after they're born. And it's a good transition, helping the baby to kind of welcome to the world. So the contents of breast milk compared to formula, obviously formula is fine. There's no harm in it. There's no reason to browbeat or shame someone for giving the baby formula. But if you're given a choice, it is certainly preferable for the baby to have breast milk. The formula has been formulated to be very much similar to breast milk, but it's not exactly. The immunoglobulins, the growth factor, and all of the prebiotic oligosaccharides. Those are the longer chain carbohydrates that are not broken down immediately by the GI tract, and they stay in the gut. And that helps to feed the trillion of bacteria and viruses and other stuff that grow in our healthy gut. and that helps to protect us from bad bacteria and other kinds of stuff. And it also helps us to get vitamins that we need, B vitamins, vitamin K. All of those are developed, and also, as well as the short chain fatty acids, would help to coat the GI tract and to protect it. All of those are stimulated and nurtured and encouraged by the use of breast milk as opposed to formula. The other benefits, this helps to protect the neonatal GI tract, helping to decrease risk of diarrhea, increases the absorption, and of course the breastfeeding is excellent parental mom baby bonding, and if women are also able to pump or manually express, getting extra breast milk allows the partner to also bond by helping to feed the baby breast milk. So again, the breast milk as well as the colostrum are really is tailored to what the baby needs now. The composition will change as the need of the baby changes. So preterm babies, as I said, there are more antibiotics and also antibodies and protein in it that's different than in the term. In addition, as the birthing person is exposed to the ills of the world, they develop antibodies. Those antibodies then passively increase the baby's immunity to ability to fight those things that the breastfeeding person has been exposed to. And it's a great passive immunity that baby help to protect it from all the stuff that's in the world. It also decreases the risk, particularly in preterm babies, of getting necrotizing enterocolitis, and as well as, again, it's us the infections, the otitis, the long-term, the late chronic infections, the GI infections, the diarrhea. All of those will be decreased with the use of breastfeeding. In addition, it has been shown that babies who breastfeed, it also stimulates the development of white and dark brain matter. So that helps them to mature also neurodevelopmentally. These things, again, just sort of beat you up, that these are all decreased with continuous, with this 6 month breastfeeding. Any breastfeeding is good. So if only 1 week, 2 weeks, 3 weeks, 6 weeks, that is better than none. Ideally, 6 weeks is a goal, but any that is done is better than none. So that's to relay to birthing person that there is no shame in breastfeeding for 2 weeks and saying I can't do it any longer. 2 weeks help the baby, and that's better than none. But it does, if they can continue, their health is improved. They have a decreased risk of ovarian cancer, which we know is really hard to diagnose and is a killer oftentimes by the time it's diagnosed, it's identified or even suspected. So if there's something that can decrease, that would be a real bonus. But heart disease also, and some of that's by decreasing the risk of hypertension, also diabetes, and also obesity. That helps to decrease the extra weight that was gained in pregnancy, and that helps to decrease the risk of heart disease and also diabetes. The also osteoporosis is with breastfeeding, that, and as well as it decreases the risk of postpartum depression. We know that it is certainly cheaper than formula. It's easier to carry around than formula. You don't need bottles, you don't need to sterilize it, you don't need special nipples, and it's just a lot easier. Having done it, I think it's just the way to go. I can't imagine having done mixed up and done formula. But um, it is also interesting that oxytocin, while certainly it expresses, it causes the contractions that helps the milk to jet out into the babies as they are the nursing. But it also has it also is a relaxant. It is a serotonin-like substance that causes the mom to relax and also the nursing baby to relax and to be calm. As I was saying, that autoimmune is a real concern that there's so many women who are affected by it. And there's a lot of concerns about breastfeeding with autoimmune disease, breastfeeding with diabetes, breastfeeding with any chronic condition. The concern is whether it's going to affect the condition or whether the condition is going to affect the baby. And so that's a real concern in talking about who might want to breastfeed, and just encourage them throughout the pregnancy that this is a good thing you might want to think about doing. We know that all of these conditions oftentimes are reasons that people don't want to get pregnant because they think that there's a condition that may get worse if they got pregnant, or they think they can't take care of the baby if it's that. So part of if they do that and reassuring that pregnancy is possible and will be okay, is that you also might want to consider breastfeeding because that can help to make all of that a little bit easier as you go through it. And these are some of the autoimmune conditions. Again, some people think it may be contagious and they can actually give the baby the autoimmune condition. That is not true. All of these conditions are much more common in females than they are in men. So, and it strikes women often, and the women are most affected, often the largest group in the reproductive age. So that's when pregnancy becomes a concern. Should they get pregnant, not get pregnant? And if they get pregnant, should they breastfeed? We know that breastfeeding does not increase the risk of flares. We also know that most medications, it's rare that a medication would have to be stopped in order to one continue pregnancy or if they wanted to breastfeed. And just these two, methotrexate and mycophenolate, those are the only ones that are really would be someone who would be on these that may want to consider not breastfeeding. But for the most part, if they can take the medication when they're pregnant, they can take the medication when they're breastfeeding. And again, this is the organization I belong to. If there's any of these medications or any concerns about what a condition might do to a pregnant person or what it may do to someone who wants to breastfeed, this is an organization that you or anybody can reach out and get evidence-based information. But it's not just information like Google they just give you, but they'll actually give you an opinion about this is not something that could affect you. You don't need to worry about it, and they can give you the evidence to support that. Again, we know that breast cancer is lower if women who have breastfed, and most importantly, again, ovarian cancer, because we really have a hard time diagnosing it. And by the time it's diagnosed, it's kind of like, it's just hard by the time you find it. So if you can decrease the risk, obviously that's a good thing. And also, we know postpartum depression. We're not talking about the blues that can happen, just sort of a wild mood swing and maybe 1 or 2 weeks after, but postpartum depression, a real psychiatric diagnosis that lasts anywhere, from 6 weeks up to years. And we know there's this case currently that three young children were killed by their mom, and they're looking at postpartum depression. It is a real thing, and they should be treated by mental health therapists who know, and they're now a new agent, a new FDA-approved medication for postpartum depression, but that is something. We know that all of these signs and symptoms really should call out that this person needs help. They're just robotic, they're not talking, they're anxious, they have no interest in the baby or themselves, and that really should raise flags, obviously. We know that there are risk factors, and if someone has these things, they should be evaluated, managed, anticipated that this may develop, and those actually have those connections to mental health counselors before they're pregnant if they have these risk factors and may develop postpartum depression. We know that individuals who breastfeed are less likely to develop postpartum depression. However, it goes back and forth because individuals who have postpartum depression are less likely to breastfeed. So which comes first and which is more important? But certainly if they don't have depression already and they're breastfeeding, they may be less likely to develop depression. But if they develop depression, they're certainly going to be probably more likely to not breastfeed. So that's something maybe, and that haven't, something could be studied, I suppose, be something we could be, looking at. But maybe if you could work and encourage throughout pregnancy so that breastfeeding is planned and it's begun, maybe that could be a tool to decrease postpartum depression. So we look at all these things that breastfeeding associated with improved outcome. So lower risk of SIDS. So if you look at the columns, if you look at breastfeeding, if they breastfed, they have a 40% decreased chance of developing SIDS compared to someone who did not breastfeed. And then if you look at neonatal deaths, so the infant mortality rates are lower individuals who breastfed, anywhere from 51 to 19% decreased risk. And if you look at where are we down at the other side, lower respiratory tract infections, diarrhea, all the infections that I talked about earlier, they're all decreased. And that's if they breastfed for a month, 2 months, and there is a dose response that the longer they breastfed, the lower the risk reduction for all of these conditions. So since they're all so good, why wouldn't anybody breastfeed? Why would you not breastfeed? So they looked at women who had uncomplicated pregnancy versus high-risk pregnancies. And it's interesting to me that individuals who didn't breastfeed, it was that the mom was sick. So we know that people who have high-risk pregnancies, it's oftentimes because of a medical complication. Well, if it's not, targets are not met during pregnancy and they don't achieve the goals, it's not likely during labor that they're going to get all complete better. So trying to get that before they deliver and then focusing on how to keep them feeling better so that they might want to breastfeed. Or if the baby's sick, if the baby was taken to look at reasons why, they were the reason. I can't remember, but if you look down, babies were taken away 31%. So 31 of the half of the ones were taken, it was because babies were taken away from them, or that they didn't get skin to skin. And skin to skin is the baby friendly hospitals. As soon as the baby's born, the baby should be wrapped to be dry, but not hands wiped off, and the baby should be put on the mom's chest. And so while she's having her lacerations repaired or placentas removed, it's really awesome. And I really didn't know this because when I trained, nobody did this. But that babies that are left on the chest and left alone, they will get to the nipple, which is just so awesome. The other reason that women did not breastfeed is because the baby got food, which is something I grew up with. My training was like always. I was a resident and a medical student. The baby was over in the corner and they were sticking a bottle with formula in it before we even got out of the room. That was just standard of care. We don't hopefully do that now, but that is a reason why they didn't then start breastfeeding right away. Or there are some cultures where babies are giving herbs and or some meat, milk, or other things, and that's just how you do it. If that happens, then it's less likely that they're gonna start that bonding and breastfeeding in the first hour. We know in women who have high-risk pregnancies, there's a lot of stress. Some of them are being managed now. We didn't do this, but now we're beginning to realize that there's trauma. And there's now some care, post-traumatic stress care for people who had traumatic deliveries. So that's, near death to mom, to the baby, to traumatic the cesarean delivery, anesthesia complications. All of those things obviously can cause stress and anxiety and may impair the ability or even the interest in breastfeeding. We know that just if you've had a 10, 20, 30-hour labor, you're going to be exhausted. And it may be that, not only breastfeeding is an interest, but that seeing the baby may be the last thing in the world you want to do. So all of those things taken into consideration, those are barriers to breastfeeding. And those are things that I think we're beginning to become aware of, that there's so many benefits for the birthing person and for the offspring that it's worth figuring out how to get over some of these barriers that we're now recognizing that they're existing and we just never focused on it. So that is something that, baby-friendly hospitals and some of us who are now new to this field really realize that there's things we can do, and that should be something we can think about. Are there questions? Any questions?
No, Dr. C, we don't
Okay.
see any in
Okay.
the chat right
Okay.
now.
So,
You guys can
okay.
drop your questions. We'll take them as they come along.
Okay. All right. So,
Oh, wait, there is one.
okay.
Does large amounts of magnesium affect breastfeeding?
Mm. No, it can make mom sleepy, but it doesn't prevent the breastfeeding. But I think that's a great question. Thank you. But that's back to where I was saying that's like the post-traumatic stress. That's the stuff we've been so focused on. Either the mom had preeclampsia with severe features, and we're so focused on getting a preterm baby delivered before they develop eclampsia. So there's no evidence that magnesium affects breastfeeding, and it should not be a reason to not do it. But it is almost certainly a reason why the care providers are not focused on encouraging that birthing person to don't worry about all these IV lines going and the beepers in the room and your heart monitor and all this stuff, but you really ought to think about breastfeeding. So it's not the magnesium, it's the situation that we create for that person trying to take care of their health care and that breastfeeding is sort of to the side. But what I would hope is that we're starting to get to the point that there's so many benefits to both the birthing person and the infant that we ought to have somebody on the team that kind of focuses on that. But to answer, no, but by itself, magnesium does not. Thank you for that question. So,
And
mhm,
one other question I think
sure.
that I would ask doctors, the delayed latch and separation. Generally, babies that are born with to mothers with GDM are at higher risk for neonatal hypoglycemia, right? And
Absolutely.
so,
Well, that's a
um,
reason to collect colostrum. Yeah.
uh, can we talk a little bit about that?
Sure, sure. I mean, as I said earlier, the colostrum, people who are going to be more at risk for developing preeclampsia, sorry, preterm deliveries could consider collecting colostrum, or certainly someone who has gestational diabetes. That neonate's going to almost certainly be at risk for hypoglycemia. And most often they go to the neonatal intensive care unit where they get a heel stick and they're watched for a while to make sure they're not developing hypoglycemia. But those would be that would be great babies if they're able to latch and be allowed to. I mean, one of the things they can't just let them, those babies are almost certainly not going to be able to just stay on the chest and hope that they latch. So those would be really great babies to have some colostrum available if mom was able to collect that, freeze it and then bring it to the labor so that they can have it there. And the baby can get that immediately, which would be great. But clearly, if there's a problem with the baby, they're not going to put them on the breast on the chest and let it eventually get to the nipple. That's not going to happen. So, but the question is, that would be a really good person to maybe think about anticipating and then having something to be able to give the baby immediately. So, other questions? We're good. So another barrier is this the barriers one to the gestational diabetes or all the other endocrine disruptors, the preeclampsia, lupus, gestational diabetes. All of those are sort of endocrine disruptors, and so they may delay the release of oxytocin, and so there are some cases where the milk is not produced immediately. But that's the case when we could, again, just to encourage to maybe collect some of the colostrum or whatever is produced, and then to then help to increase the fluid intake and just the frequency of nursing helps to increase the amount of milk flow. So that's part of the education to someone who may have a condition where you might suspect that they're going to have some problems, difficulties breastfeeding. The other thing is the trauma of surgery. Even if they have an uncomplicated cesarean, the fact that they had surgery, they had anesthesia, and it's loud in there. So, to have the baby on the chest to try to nurse as they're getting sewn, we've tried to do that, but it's probably not ideal. But, something that can be done. But those are all barriers that and can be anticipated if you're thinking about breastfeeding is important. I think you have to start with we as a specialty, my experience has been that breastfeeding is sort of an afterthought. It would be nice, but we haven't really thought about it as really an intervention to help as sort of a public health intervention for the birthing person's health long term and the offspring's health long term. So once you get to, we really want to help you do this, all these other barriers, we need to figure out how to do that. So I think that's just sort of a sea change for me anyway. And we know that individuals who have health complications is going to be more likely to focus on those health complications than they are their breastfeeding. And that's certainly, I think, something we should think about. We know that on the other side, not just the moms, but babies who are separated. So moms who have GDM, those babies are going to go to NICU most likely and get heel sticks and make sure that they don't have hypertension, if the hypotension, if hypoglycemia, if the mom has preeclampsia and baby's growth restricted, more likely it's going to go to the NICU. Those they're going to be separated, and that's not going to do that. They're not going to let that baby stay on the chest and do skin to skin. So those are cases where we know it's not going to happen, and that's when we should anticipate it and have a plan for how we're going to help that person either express manually or with a hospital breast pump and help them to establish that bond and begin the nursing. We know that preterm babies are fragile and they are not likely to be able to easily latch and suck. So those again, where it may be useful to collect the colostrum and give it to the baby in a spoon, and we can, those are some techniques. But once we got to start with, we want to help them to breastfeed as opposed to just figure out how to get them through this pregnancy and get the baby delivered. But breastfeeding needs to become a part of what we're trying to do. And we certainly know that donor, it can be supplemented with expressed milk, be supplemented with donor milk, and then if need be, the formula. And then the crawl, which is something I didn't even know anything about until the last couple of years. Never, when I trained, did anybody even think about that. But it's just so awesome that babies who are put skin to skin, which we now do in baby-friendly hospitals, the emotional connection, the actual motion, the mobility of the baby to get to the nipple is just kind of awesome. Babies need to be wrapped and just covered, certainly they're wet. And most delivery rooms are freezing. They're comfortable for surgeons, but they're not great for wet babies. So clearly, babies are going to have to be in a blanket, a warmer blanket. But their hands shouldn't be wiped off because the amniotic fluid is used in the baby's mouth and can help, it appears, help to direct the baby to the nipple where the colostrum, I'm told, smells like amniotic fluid, and that helps the baby to get there. We know that right after delivery, babies cry generally. They don't have to be beat to spanked and turned upside down. And then they rest. And if we allow them to rest, they can rest on their mom's chest. If there's not a medical reason why they have to be wrapped up and sent to the nursery or wrapped up and put in the bassinet, but generally just on the mom's chest or the belly. And then the baby will gradually wake up and they'll smell the amniotic fluid or the colostrum and literally crawl and wiggle to the nipple. And it's called the breast crawl, which is just so awesome. And then without pushing the baby's head on the nipple, the baby will find the nipple and will latch itself if you allow it to do as opposed to. And they root and suck. The other thing is that in the process of pregnancy, we need to help moms to know about signs that the baby's hungry. The baby's looking around, smacking his lips, sticking his tongue out, grabbing his hand. That they shouldn't have to cry to know that they're hungry. That used to, and the frequent breastfeeding will also increase the amount of milk that's available. And there's a baby breast call that you can look at the crawl for like 20 minutes and you'll see the baby move. I'm going to show the last 4 minutes, which is just so awesome, that the baby literally goes from the chest and it wiggles its way to the breast, which is just, I think, amazing because I didn't know that until like the last couple of years. And I feel like I was deprived in my training, but it's just awesome. But that can be done. And I think that once we decide that that's something we really want to do, that we just need to figure out how to get rid of those barriers for the mom.
Can see the areola. If baby raises a head, it can also see mother's face. Baby has reached the nipple, has raised her head, and has nicely lashed it with wide open mouth and mouth.
I just think that's amazing. So babies will do that if we allow them to do it. And I just think it's a sea change that we have to decide no matter what the complication is or what we're trying to do to make sure the mom and the baby's okay, that breastfeeding needs to be a part of it. Clearly, there's some emergencies and some conditions where it's just not going to happen, but there are barriers, and I think that we overcome other barriers, and that's just something we should do. So again, I just want to finish up with Mother to Baby, which is the oldest organization. You can sign on there. Signing on is free, but if you join, it's really, I think, great because they do wonderful things. But you can get all kinds of information. So it's available to patients, to providers, and you can get just all kinds of stuff about, and this is all evidence-based stuff. So about people have questions about vaccines or antibiotics, or any medication they might be taking. if by chance they had a glass of wine and they didn't know they were pregnant. Is that horrible? So they can read about and they can also send a question in and they will get a personal answer about, the timing of the wine and how much and just kind of bring people down. And so all of these diseases, there are things in there that you can, there are articles and also webinars that they have. And any medication or any, if somebody's working in a industry and they think they're exposed to stuff at work and they think, the toxic mercury or they're concerned about that, all of that stuff can be gotten here. And the other thing is really nice is if you have anybody who is on a medication or they're regularly treating for something or maybe a combination. If they want to join a study, this organization has they have several observational trials just to collect data so that when we want it, because most, as you know, most things in pregnancy are done because we've always done it that way. There's really very little evidence based in most of the stuff we do. So what they're trying to do is to collect information, objective information, prospective information about exposures during pregnancy, exposures during breastfeeding, so that they can actually, in responding to questions, they can actually, as we often say, there's very little data, but we don't know that it's harmful. But if we collect 100 patients who've been on that medication and there's not been any untoward event, well, we can say it's not powerful enough to say absolutely not, but it's sort of reassuring to people that probably it's okay. Um, okay. So just want to conclude that for what I do, high-risk pregnancies, hadn't for 40 years thought much about breastfeeding, but now I'm a big proponent. And I know that because of a lot of barriers that we impose and just the nature of the conditions that affect high-risk pregnancies, they're going to be less likely to breastfeed and they may have more problems breastfeeding. But I think being aware of that and understanding the benefits for the birthing person and for the offspring, that it behooves us all to think as much as we can to help them, one, to be educated, but also to overcome any barriers that might be in either from the condition itself or just presented because of the medical system that we exist. And we know that the first hour is really important in just starting that process. And then the more frequently individuals breastfeed, hydration, and all of that is just really increases the chances of success for the mom and for the baby. So thank you.
Thank you, Dr. I always want to call her Dr. C, but I should say it formally when we're not
No, that's
when
fine.
we're in public. Thank you. Um, Jamie shared that Global Health Media also has a really nice video illustrating the breast claw called Early Initiation of Breastfeeding. It's just amazing to me that the
Mhm.
little guy could do that. I
I
clicked.
just didn't know. Honest to God, I mean, I literally in 1970s and 80s, it amazed me that these nurses were so good. They'd go in there with these towels and they'd wrap the chest and they'd I mean, these women would be flat and we'd give them testosterone. And it just never occurred to me, because nobody ever told me, that this was not a good thing. I mean, we're like getting rid of all that. I just can't believe it. But yes, and so now it's just incredible. I mean, that you leave them alone and they will wiggle their way. Not only will they wiggle their way to the breast, but they will latch themselves. So because now, we try to open their mouths and we try to put it there. But I mean, if you leave them alone, they'll wiggle and do it themselves. It's just awesome.
And so when we talked about very briefly for the mom with gestational diabetes or in those instances where there may be a delayed milk supply, we said mama can start to collect her colostrum starting at what?
Well, for someone who has diabetes, I wouldn't start much before 38 weeks because we don't want them to deliver preterm. So, but for anybody who uh, um, doesn't have an increased risk for preterm delivery or have diabetes, I think they could start at 37.
Okay. And then I think it was Jamie had shared that well, let's go back to the GDM mama. So she collects her colostrum, she freezes it, and then she takes it to the hospital with her. and and then she ensures that they know that she has it so they don't introduce formula
Formula.
or
Mm-hmm.
something else.
Mm-hmm.
Um, and then Jatoya had shared that the support person can do skin to skin and provide the colostrum until
Mm-hmm.
mom is able to.
Mm-hmm.
Um, other questions that you guys have for Dr. C while I've got mine. I can keep going. The other question I had, Dr. C, is so often the doctor will or the support staff or the nurse may automatically default to recommending formula
Oh
because
yeah,
mama has a
I grew up
complex
that way. Absolutely.
diagnosis. How can that, as a patient, how can we constructively push back or share that we want to try to nurse if I've got a complex diagnosis?
You
What's
just
some of the
have to do
language
it.
we
I
should
just
say?
I tell I talk I mean I discussed this during my prenatal visits and I just tell them if you and I tell your support person you want to breastfeed and you go in there don't because they'll say do you want to breastfeed or formula. You just walk in and you make the decision and tell them that you want to breastfeed and that either you have colostrum or you've already started it because if you go in and you declare that you want to breastfeed, they've heard you as opposed to what is just a lot easier for them to say, you don't want to breastfeed, do you? And then they have the formula already. So if and by the time they say that, you've gone through labor, you're giving medication or you're just exhausted and you just, yeah, whatever. But if you make the affirmative decision and your support person says that's what you want to do, then you're much more likely to have it before realizing the next day that your baby's already had three formulas and you haven't even started breastfeeding.
That's a good. I mean, it should be part of an integral part of your birth plan. I mean, I know we discourage people from saying, "Oh, I want my birth plan carved in stone," but that should be a
But
conversation.
I think this one is because when you go in, they're doing the intake and they're taking you. So, well, they ask you who your pediatrician is. They ask you, what else do they ask you? They ask you about your vaccinations, and then they ask you, tell you they're going to put the silver nitrate in it. They tell you all this stuff, and then they'll say, breastfeeding or bottle, and you just need to, you start out by saying, my plan is to breastfeed, and that's what I want to do. And then your support person say, no, 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 we're breastfeeding. Because it's just so easy to just wrap the baby up, put it in the corner, and say, well, I'll give it a bottle, and then tomorrow they'll talk to you about breastfeeding. Well, that's not the right way to go.
Right. Are there, going back to your slide with some of the chronic
Hmm.
illnesses that you care for, asthma, are there any
Hmm.
asthma medications that would preclude mama from
Absolutely not.
breastfeeding?
Absolutely not. The only two that I listed on there are immune modulators, and it still may be beneficial, but that's the shared decision making about the potential risks. But no, not any asthma. And particularly if
And,
it's steroids, no. Mm-mm. No reason to not. No reason to use that as a reason to not breastfeed.
and then was it for those of you that were with us yesterday, we had a conversation, was it yesterday with or was it earlier this week? We had one of our um educators that shared some, Karen, I know you were here. It was with you, was it with your speaker about the mama the new guidance around mamas who are HIV?
Oh, well, there's new guidance that for most of the world where you have to worry about for the most of the if especially well 100% if their viral load is undetectable, there's no reason why they can't breastfeed. And particularly even if they are detectable in some parts of the world where um, getting clean water and mixing safe formula that it may still be the preferred method to feed the baby, given that the water supply is not safe. So again, that's about deciding, talking about the risks and the benefits. But if they're HIV, if they're undetectable and undetectable viral load, there's no reason that they can't breastfeed.
And what I'm showing for our nurses that joined us tonight, you guys, you have an opportunity to earn 1 CE. This is the QR code for you to access the 5 question, believe it is, CE. And then if you don't have the ability to, give me a sec. You don't have the ability to scan. I will drop I'm going to try to leave that up and then go over and get
I'm going to answer a question.
go ahead
Um,
and answer.
There's a question about no, if the support person has to express the milk and give it to the baby in a bottle, that's not going to make it more difficult to breastfeeding. I mean, no, it's not, because one, the baby has gotten breast milk, and that will become a preferred food because it got breast milk. And then and the bottles, there's no harm. Even if you're breastfeeding, you can still use the bottle, because that way your partner can also breastfeed the baby and also give you a little bit of breast. So no, I mean, ideally it would be better on the chest, but it's still not going to be difficult. It's still possible and not complicated. Still the preferred to using formula. And also the expression will actually help to start the milk flow. So that'll get that hypothalamus to start producing and end up with the pituitary producing the oxytocin. So no, that would be the ideal thing, is that the partner can express, which will get that milk axis going. And then when the baby's able to get on the nipple, then that would be fine.
Then there's a question about breastfeeding with implants.
That will depend. What is it? The colostrum will keep it in a
That she's going back to answer my question about
so like in a syringe.
pre-expressing.
In a syringe,
Yes.
right?
Um, and often you're like, I know Mead Johnson, if you were to reach out to them, they had those colostrum containers. They would
Mm.
send you a few of them at no cost back in the day. Thermo Scientific as well. You could probably buy them on, and
Amazon probably.
Amazon,
You
and they're
probably get
fairly
them on Amazon.
inexpensive. Yeah, everything, you can get on everything on Amazon, right?
Yeah, right,
And
right.
stored them.
Yeah, the implants, you really just have to see why did they have the implants? If they had, malignancy, is there breast tissue there? So it really, unfortunately, that has to just be tried, and you'll have to see. So you can't really say, unless you just need to know why it was done, why the implants were done. It was just cosmetic, and none of the breast tissue has been removed, then that shouldn't be a problem. But if they'd had a malignancy and some breast tissue was uh, removed, then that may be a problem.
Oh, that's a good point.
It's a new thing, something new. Oh, your contact hours.
Yes, doulas, you'll email us and for your certificate, for your contact hours. And then for nurses, there's a link in um, I dropped the link for you, or you can scan the QR code for the Survey Monkey. Um, any other questions? I think there was a conversation about cannabis, the use of.
Yeah, well, that's interesting. Go to the mother's the Otis site. We don't know. There obviously, I tell people all the time, there's not a lot of randomized clinical trials in pregnancy. I mean, you're not going to get 10,000 pregnant women to say, I'm going to do cannabis, and then 5,000 not. So we just don't have the data. But as far as we know, using just case reports and just some animal studies, it doesn't appear that cannabis with breastfeeding is harmful. The recommendation would be the same thing as with alcohol, that if you're going to do it, you should breastfeed the baby, do it, and that way 2 hours will pass, so you're not exposing the baby as much. But there's no data to say that it is harmful. But of course, nobody's really studied it.
I think the other thing is that you don't know what, from one cannabis source to the other,
True,
correct?
true,
Um,
true.
and yes, am I saying this right? Rasha, Rasha. It's the same email. Bright girl, yes, it's the same email, the same people that um, send you the reminders. You can reply to that, and um, they'll send you the certificates. Well, thank you, Dr. Henderson,
Oh,
so
well, thank
much
you
for
for the
this.
honor.
We will send the recording of all of our. We'll send all of them at one time by that same email. You'll get those from either Sheila or Ravimbo. If you attended several webinars this week, will we get a contact hour for each webinar as a doula? Yes. And I have not heard back from Nakia about Monday because our agreement with her was that we would do one contact hour for each um, session. And I know Monday we went, or Tuesday, we went to two. And so we had asked about getting an adjustment for that one. I have not heard from her, and I know the girls had already started sending out the certificate that she had sent with no designation on it as one. I think it was just that the one. So we haven't heard from, I know Ravimbo had asked me about it. Is breast milk used for infant on NG2 because of inability to suckle?
I think it's likely because then if they could, they would just either just give it with a spoon. My guess it's just a very, very preterm baby, or maybe even there's a fistula. I mean, if there's a esophageal, a tracheoesophageal fistula. I'm assuming. Well, there's some medical reason that the baby's not swallowing. I mean, there's some GI tract problem, or this baby's just so premature that it can't.
I think so too, because I think that, right, with the preemie, they try to avoid using formula.
Oh yeah,
Because-
yeah. I
Yeah,
mean, they really encourage you to do that, and then they have all these refrigerators that keep you. They would encourage that.
I know. Uh, that would be a question, Trudy, for the neonatologist. Were you in the session yesterday with Dr. Wilson? Did you ask that question with her yesterday? That would be an email to, that would email that to email her that one.
But I
Oh,
mean,
you
that's what I'm
want,
saying. There's the medical problem that they can't swallow. So yeah, I mean, there's some medical problem that they can't swallow. So it's
yeah,
either a
yeah.
neurological medical problem or the tracheoesophageal fistula. There's some mechanical medical reason that they're not swallowing because they much prefer to allow the baby to, or the baby's just so premature it can't suck the
Right, right.
neural
Yeah, Looney. They really try to avoid using infant formula with preemie babies because it can and certainly not until they're at least 32 weeks because cow's milk protein can cause neck. He had suprabulbar palsy.
They couldn't
Um,
swallow. That's a neurological problem.
yeah,
Yeah.
to babies, the IUGUR.
But that's
Um,
interesting because and it's interesting because the composition of the breast milk changes to the baby's need. So babies that are preterm need higher concentrations of protein, and that's the case. So if the baby's growth restricted, the problem is that many babies who are growth restricted are just small and then normal. So we really don't distinguish often between babies that are normal and small and those that are growth restricted. Babies that are growth restricted and small may have metabolic changes because they didn't get enough oxygen, enough blood. And those babies may need different, their needs may be different because of the metabolic damage they had in utero. And the breast milk changes, which is just so awesome. But oftentimes, babies that are called growth restricted are actually just small and normal babies. So as I tell people, if you're normal, there's no harm in being small. But that's where they start doing Doppler studies and looking at growth. Babies at the end of pregnancy should grow about 100 grams a week. And if they grow 100 grams a week, they're small and normal. And so really it just depends. If the baby really is growth restricted, then it's going to require extra metabolic support. And the breast milk it's amazing that it will be adjusted to that.
And they can take because your average breast milk is 16 to 18 calories per ounce. And so what they can do is take mama's milk, which is the 16 to 18 calories per ounce, add
Protein.
donor milk or human. I don't know if you guys have ever heard of prolacta. It's where they take donated human milk and they swirl it
Spin it
around.
down. They get the sediment.
And,
But I think that But the
And
issue is
they,
milk adjusts to the baby's needs. I mean, I
well,
would.
that's the mama's milk, but if they take donor
Oh, yeah,
milk,
yeah,
like
okay, okay. No, yeah,
Lacta,
no,
right?
no. Then yeah,
And they
right.
and then the
Yeah, they'd have to you
NICU,
concentrate it.
right? They have what they call human milk fortifier, and so the prolacta, it's made from donated human milk, and it's a fortifier, and it looks like it's a little vial, and so they take donated human milk, they extract the protein and fat, and they can add that to mom's own milk to increase the calories and protein to make they take so then that 1 ounce that starts at 18 calories can be fortified to 20 calories, 22 calories, 24 calories, 26 calories.
But they have to
So
be careful because that's when you start getting into neck. If it's so concentrated, then you start
not if it's human milk, not if
okay,
it's human milk, but if they use it with formula,
okay,
yes,
get the neck.
because the cow's milk protein can cause neck, but a human milk based feeding doesn't cause neck. But with human
Yeah,
milk, no.
right.
But for an IUGUR baby, I can use a human milk based
Mm,
supplemented mama's milk and feed that higher protein. But if the IUGUR baby is term, I might use a bovine
yeah,
based for, yeah, Gina, you're right. If it's an IUGUR and it's a term baby, I
right.
might. And there are no other complications, I might use a bovine. Yeah. If that's the only complication, Looney, is it's an IUGUR and it's
But
term.
generally, if it's a real IUGR, there's something else going on because that's how I got to be IUGR. That's the tricky
Something
part.
else is going on.
That's the tricky part.
Yeah. But yeah. But there's always that's what makes medicine
Yes,
interesting to me.
interesting. Keeps us on our toes.
It's
Well,
in
that's
there
why I
with
just
all
learned so
that.
much because I've not, I mean, when you asked me to do this, I thought, well, I don't do breastfeeding. I don't know. But I mean, I realized I mean, I've just been my whole training for 40 years. It's such a loss. I just don't understand why we did that. I mean, I do know why we did it. That's why I did the social determinants of health because it's, from enslaved women. I mean, that's just what's been happening. And we just, I mean, when I had my son who's 30, almost 37, my mom said, well, we just don't breastfeed. And I said, well, you only have one kid, me. What do you mean we don't breastfeed? And she said, well, we just don't breastfeed. I said, well, why? Because we don't. So, oh,
See,
okay.
my daughter was 43, and my mother said, if that boy couldn't afford y'all, why'd y'all get married? Because back then it was
You,
only poor
breast,
people
yeah.
breastfed.
Well, that's the thing. Right. Exactly. That all that, it literally, it starts from slavery. It really does. And it would just keeps it up. Yeah, exactly. Exactly. And
But
so
now we know.
and
And
we
then it
know
was like, well, only the like California tree
hippies,
hugger
the hippies,
vegan.
the hippies,
But hopefully we are
educate.
pivoting and our we know better, and we know the benefits. And
Yeah.
you're and when Christina earlier this week was talking about neck, it's very much a concern in the unit. And the challenges in particularly with more rural hospitals or hospitals that don't have larger budgets, donor milk is not inexpensive.
No.
And donor milk tends to be from mature women who have their babies would be older, right? Because it's often a woman who has nursed her baby and now she's donating her milk. So as Dr. Henderson has said, your milk adapts to the what your body thinks the age of your baby is, right?
Yeah.
So
Amazing.
if she's donating now that her baby's older, that milk is not
Right.
precise
The
to your
preterm.
baby needs,
Right.
right? And so you want your baby to get mother's own milk. So as a doula, as a grandma, as an auntie, we want to encourage our mamas to provide their own milk for their own baby as best they can. And so the key is to get our community to understand how critically important it is, and remove the barriers. I mean, I understand. I remember when I was in Rio Grande Valley in Texas, And I was talking to a hospital executive, and he was like, well, the women here don't breastfeed. And we went around and around, and it was like, well, the women in your community are working in an
Yeah.
aloe vera farm, like out in the farm.
Yeah.
Well, they're not breastfeeding because they know they don't get maternity leave,
Yeah,
and they
exactly.
literally have to go back out in the field. But
Exactly.
how about we talk about getting a generator and we get refrigerators, and then you guys give them a break, and then let's see what they do. Because once we have resources, yeah.
But it has to be prioritized. I mean, it has to be deemed as important.
This is so interesting. I had no idea about Prolactis. So much valuable information in this class.
Mm.
Yeah, they are a multi-million-dollar company that
Mm.
has profited off of um,
People's milk.
premature births.
Yeah.
But it's a if women
Yeah.
benefits of the placenta. Now
Yeah.
that's a whole other
Another
conversation,
talk,
Kim. I
another
don't know a whole lot
conversation,
about the placenta.
another
Unlike
conversation.
Dr. Henderson, I never spend a lot of time on the birth side because I can't stand body fluids. So
Well, don't look at the placenta then.
no, ma'am. I had to close my eyes Tuesday when Christina showed the neck pictures. Yeah, no. I stayed on the NICU side. I can tell you all about the babies,
Little
but when
babies,
you
little
start
babies.
showing all the body fluids, I'm on the floor. Yeah.
Yeah.
So, but I'd like to, we should the placenta encapsulation. You guys can do a workshop on that one, and
Next
somebody
one.
else,
Yeah.
Karen, can host that one. She'll even have to turn on the Zoom because I'll be in another room. So, but
Yeah.
anyway, well, we appreciate you all joining us this week, and thank you,
We
Dr. Henderson, for
apologize
your.
for the Zoom faux pas.
I hate always doing that to you, and we thought we had it, but we got
I
it.
know we
We
started
solved it.
early and
We
I actually have
solved it.
I have two computers because they said it'd be easier to do two. I mean, yeah, I
We
tried.
solved it faster than the norm. Oh, wait, there are three questions and wait, there was questions in the Q&A. Is breast milk used for infants who are on NG tubes? Oh, that we answered that one.
We answered that one.
Because of the inability to suckle, I think we answered that one.
Fine.
When do patients need to see maternal fetal medicine specialist in addition to their OB/GYN? Is a visit not too excessive? Ooh.
Whenever they have a problem, they have those high risk things. That it depends on where. Some places in the country, if you have a problem, you go to maternal fetal medicine and they do it all. They see you for your OB, they take care of the maternal fetal medicine, and then they deliver you. But more likely, what's happening now, what's more common, you see your OB, and then if a problem pops up, then they will manage you jointly with the MFM. So, if a problem develops, the baby's too big, too small, you have high blood pressure, diabetes, whatever. If there's a problem to manage you with your OB, then you would. But if you didn't have any of those, you would not necessarily see an MFM.
Thank you. I'm glad I saw that little pop up. Thank you so much for
Thank
joining us
you.
this week. Thank you, Dr. Henderson, as
Thank you.
always.
Thank you. Thank you. Thank you.
Our next series will be in September after Labor Day. Our first workshop, or our first event, will be September 15th. We will be joined by another MFM out of Southern California, Dr. Yukachi. We're going to do a series with her on fibroids.
Hmm.
So if you're a doula, you should join us because fibroids are much more frequent than we realize, and mamas need support. And if you are a woman who either struggles with fibroids or you think you may have them, so often we don't even realize.
Hmm.
And that is one of Dr. Yukachi's specialties. And then we are going to have, for our book club series, a conversation with one of my favorite authors and one of my favorite people, Dr. Shirlene Abobi, who is a cardiologist by training, and author of three amazing books. And she's going to, they're not about medicine, but they're about medicine, but they're romance.
Oh,
Um,
okay. So
and
a,
yet
a,
you
not a fictional, exciting.
Yes, fictional romance. She's going to talk about her latest book called Die for Me. I have not read it. I'm going to read it on my vacation next week. But we're going to talk more about my favorite one because I'm her auntie and she has to honor my wish. It's called Between Friends and Lovers. When I tell you this is one of the best romance novels I have ever read in my entire life. If you like, and it's set in Chicago. If you
Oh,
love romance and fashion and humans that like where you just feel like the character is someone you know, JoJo is someone I know, and I just saw her and I loved her and I knew which man I wanted her to choose. And it wasn't until the very end I knew,
just
ah,
messed
you
it
will
up.
love it. Thank you, Dr. Henderson. Willow Bushwell. It must be somebody you know. Do you
Yes,
know
thank
Willow
you. Yes,
Bushwell?
it's good to see
Willow
you.
is on with you.
Thank
Yes.
you.
And
Thank you for
so,
joining us tonight.
yes, Willow is there. Oh, you're reading the book,
Oh, you
Isali.
love it.
Oh, thank you, Isali. You're reading it now. So you're going to be there. Okay, you guys have to go get this book.
Okay.
Am I fibbing, Isali? Is it a good book? I almost want to take you off mute so you can like echo
Um,
me if you love
I
it.
have to
I
think that
probably have
up.
read it
I'm
five
not,
times. It's
I'm
so
not
good. Yes, you guys have to get it. It is so good. And yes, it is funny. It's funny, and
funny.
there's a point in it where I cried on the I read I've got I my daughter and my grands are in New York, and so it's like a 5 hour flight, and their books every now and again I like The Wife in the Yellow Dress. I don't know if you guys have ever read that one. I
Mm.
cried in that one where like I'm on the plane and the person next to me is looking at me
Are you
crazy.
okay? You okay? All right.
It's oh wait, let me put it in the chat. Between Friends and Lovers by Shirlene. Look her up. She's got like over 100 OBUO.
Gotten into reading books that are
And when
making.
I say, I mean, she's been on Good Morning America. I need to brag on her for a moment. She was interviewed on Good Morning America with her debut novel.
Mm.
She was on Good Morning America. Her debut novel was called On Rotation, and it was like an award-winning, immediate bestseller thing or whatever. And it was about a young woman applying for med school or taking her MCATs and like a love story and all that
Mm.
too. And I loved it, but for some reason, JoJo just resonated with
Gotcha.
me. Well, you'll have to read it and then you'll say, oh, well, we know why Marie loved this one. And not that it's me, it's not my life. But I loved it.
Just have to
But
get into it. I'm a nonfiction person, so I'll have to.
oh yeah. Oh, and I did get yours. I'm going to read yours while my sister and I are on vacation.
I mean, just
The
I'm
story
getting
you
into
tell.
reading.
Yeah.
I'm into anger. I'm into anger, and I can't believe that we're doing this again. So
Oh, see, I have to escape from it sometimes. Now, the other one I got for my vacation is this one, you guys.
okay,
Working
working
Class
class.
to Breaking Glass. This
Okay.
woman, I met her 20, 25 years ago. She was the VP of Global Communications for Starbucks, Black woman.
Mm.
And when I met her, we were somewhere and it was like where people didn't know. This was back before internet and all that, where people didn't know who the VP of Global Communications for Starbucks should look like. And back
Mm.
then, I didn't wear hair like this. I always
Yeah.
wear my hair like in a little bun and all this. And we were in San Francisco, and everyone I thought I was the VP of Global Communications. No, she was because. And they thought it was me because I had like the little buttoned up suit and was pharma looking, like blue suit and all this.
You were
Girlfriend had,
corporate. You were corporate.
yes. And they assumed because it was like a hospital soiree thing or whatever, blonde dreadlocks down to her butt
Oh my gosh.
and fishnet pantyhose and these like, what are those with the red bottom
Um,
heels and stuff?
oh,
Oh, she
the
was
stilettos.
so,
Stilettos.
yes, yes. Like what's the, whatever the red shoes are. And oh, she was so cool. And she is just amazing. And I have followed her since and stalked her, and she became my friend. Um, But and so I'm excited to read her book because she just defied, like,
Yeah, the
you
norms.
are running
The
global
norms.
communications
Yeah.
for Starbucks, and this is what you look like. But she was so bright, and I learned so much from her on navigating corporate America
Mm.
and how you manage a team. Because she just people loved her, and when what's his name, the founder of Starbucks retired,
Hmm.
a lot of the original Starbucks executives left with him,
Okay.
but when he went back, he would only go back if she went with him,
Wow.
and she did.
Okay.
Because she's that good. And when I say this book is like tabbing, even with me now running a nonprofit, this is like a Bible. I love her. You guys have to get this book too.
I'll have to get that
Working
one.
Class to Breaking Glass. I mean, she
Okay.
is so, and she's originally from Flint, Michigan.
Oh, wow. I wonder what
She's
she thought
so
about the
human and
craziness. Of,
so,
wow.
yeah, just amazing. What she thought about what?
Oh, with the lead pipes up in Flint a couple of years ago. Well, like 5 years ago when they had the lead pipes and
Oh, I knew that pediatrician. I
oh
knew
wow,
her.
did
She
you
was one of my,
really?
because that was my region. I
Territory,
managed
yeah.
a sales team.
And that was just
That was
awesome.
my, yeah, she
That
was
was
so amazing.
amazing.
I don't know if Wanda knew her, but I knew her, the pediatrician, and the fight that she
They still
had with
don't, really?
him. And
Wow. Well, that's
yeah,
terrible. She said
yeah.
the chat, they still don't have clean water
No,
in the chat.
no,
Yeah.
yes. It's well, there are several municipalities in the South that have equal
Oh yeah.
issues,
I mean,
and
but you,
it
yes, but
hasn't been, and they
yeah,
haven't taken.
yeah.
So I'm trying to stalk Wanda. Like right now she's making like the big rounds, but I hope to bring her for one of our book
Oh,
clubs
that'd be
too.
fun.
So
Yeah.
because she's just the she to me that's she navigated, and this was in, oh my gosh, I wasn't even in, this was 2001.
Hmm.
So this was before, like, she was navigating the C-suite when we weren't around. So,
Wow.
so anyway, redlined in Wigger communities. Yeah, Karen. Yeah.
Yeah.
So, but no, I love to read, but I hope you guys will join us on the 17th with Shalina Bobie. And then you missed Dr. Henderson. I won't get teary when I talk about this. In October, we have Caroline Peterson. She runs an amazing nonprofit in, I don't know if they call them nonprofits in South Africa.
Mm.
But one of my dear friends introduced me to her, and we had never met in person or like on Zoom until recently. But she runs uh, a survivor. She works in gender-based violence
Mm.
in South
See, that's the
Africa.
stuff I couldn't do. That I can't do that.
Oh,
I can't
and
do
she
children and
she
I can't do
herself
kids. I
is a
can't.
survivor of gang rape.
Oh God.
And but she became a paralegal. She is a court advocate. She helps defend women who have had to defend themselves. She has lobbied to change some of the laws in South Africa. She is just, I was telling the people last night that I mean, she just meeting her was like, gave me goosebumps. I mean, people
Yeah.
that can do stuff
Yeah.
and change the
Change
way
the
the
world.
world.
Change the
Oh,
world.
and she's going to come and talk to us
On the 17th of October.
in the 17th of October and one in the afternoon, Eastern,
Okay.
because of the time difference.
Right.
But she just has, I mean, uh, she's just she's just amazing because I don't know if you guys know, but in South Africa, in some of the rural communities, with some of the like gangs and stuff, um, one of the things that they have to do to be admitted into the gang is
Oh.
to assault
Yeah, I mean,
a
I'm not
woman.
surprised. I mean, in Chicago, when I grew up, one of the vice lords said one of the things they had to do either burn down a garage or a building or rape a virgin. Yeah.
And so, and it's not like, so, but so she's just a
Mhm.
powerful woman. And so she's going to come, and I think we should learn about and it's not that our world is much different, because I don't know if you guys might, and you guys, we are done. Let me stop recording, but I'm just going to tell this story real quick, fast, because I don't want the